Well, hello everyone. My name is Michel, and thank you very much for joining us today. Today, I'm delighted to host Dr. Laurie Mischley, who will be talking to us about rebranding Parkinson's. And I don't think that Dr. Mischley needs an introduction aside from the fact that she's probably the world's leading Parkinson's naturopath. A previous webinar, just said a few seconds ago, was on what do successful people do to slow down PD progression, and it has been viewed 100,000 times. You can find it on our YouTube channel. So I think the main background to today's presentation is that despite 200 years of effort, we do not yet have a system to prevent, halt, or reverse Parkinson's. And today, Dr. Mischley will explore the notion that the problem lies in the lens through which we have been viewing it, the approaches we have been taking, and the assumptions that we have been making. So as always, I would like to remind everyone that this session is for information and education purposes only. This is not a replacement for your consultations with your medical team. If you have questions that are particular to your specific situation and want to improve your health, you need to keep them in the loop as well. There will be time for questions at the end of the presentation. Obviously, I think that we will have far more questions than we can cover, but hopefully Laurie's presentation will already cover many of your questions. If you want to ask a question during the presentation, you can add it to the Q&A function at the bottom of your screen. So for those of you who don't know us yet, No Silver Bullet is managed by Mark Lambert and myself with the aim of sharing Parkinson's expertise, like we're doing today. We post the recordings of our webinars on YouTube and Spotify, and we also post short videos on TikTok and Instagram. The details are available in the chat section at the bottom of your screen, as well as on our website. Our website is nosilverbullet4pd.com, nosilverbullet4pd.com. But let's come back to today's topic and to Dr. Laurie Mischley, who will be talking to us about rebranding Parkinson's. Laurie, the stage is yours.
Great. Thank you very much for the invitation to be back here again. I enjoyed my talk last time and have had a lot of people reach out to me as a result of it. So, okay. So out of the gate, what I would like to do is ask everybody, just based on their gut response, to choose a team. One team is called It Only Gets Worse. One team's name is Let's Find a Way. Just intuitively pick a team. Which one do you want to be on? I know so many of you are here because you want solutions for your Parkinson's, and I hope not to disappoint you, but today is less about solutions for Parkinson's and more about philosophy, the approach that we are taking as we try to get you solutions. So I want to start by a couple philosophical approach quotes here. First of them, there's a German philosopher who said in the late 1800s, there are three truths in science. All truth passes through three stages. First, it is ridiculed. Second, it is violently opposed. And third, it is accepted as being self-evident. Thomas Kuhn, also a philosopher, wrote a book called The Structure of Scientific Revolutions. And he said that when the scientific effort spent on a problem increases, but we're not getting the results that we want, we might want to step back and reconsider the assumptions and the paradigms on which we are basing the research. Maybe we're going about it wrong. Maybe we're looking at it wrong. I had the pleasure of working pretty closely with Andy Grove before he passed away. He asked me if money wasn't an issue, what would I do next? And I said, well, I'd do a phase 1 study on this and a phase 2 study on this. And he screamed at me and said, you're not listening. I don't want to hear the word phase. I asked you, what's the fastest way to a cure? It is the spirit of asking questions differently that I want to start with. Buckminster Fuller, also a philosopher, was an advocate of doing more with less. He is the inventor of the geodesic dome, and his philosophy was build things that are strong, lightweight, and resource efficient. His opinion was you can never change things by fighting the existing reality. To change something, you have to build a new model that renders the old model obsolete. So what I'd like to do here today is talk about building a new model that renders the old one obsolete. So one last quote, Linus Pauling, the only person in history to win 2 unshared Nobel Prizes, said the best way to have a good idea is to have a lot of ideas. And so that's what I'm doing here today. I am throwing out tons of ideas. They're not all good. You're not going to agree with all of them. Your other doctors and other researchers may have other ideas and better ideas. Great. I just want to be generous and free with how I'm thinking about this, in the spirit that maybe all of you will start getting more creative with how you're going about it. So I took it upon myself to just start coming up with the solution. And step one was to scrap the old system and build one that works. I wanted to create a currency. My idea was to find the people doing unusually well, define what they are doing differently, and find some way to package and deliver that, whatever it is that the successful people are doing, can we package and deliver that to everybody else? So that is where I started. And as I said, I am positive not all of you and all of your providers are going to agree with me. I very intentionally am going to say a whole bunch of highly charged, debatable, hot top opinions here. And I hope your doctors disagree. And I cannot wait to see the models that they propose as alternatives, right? I'm not saying my model is right. I'm saying it's the best I've been able to come up with, and we need something new. And real talk, before we get into the gritty stuff here, is for evolution to take place, for anything new to form, it means something old must die, right? There are people in positions of power, labs, hospitals, research centers, whose entire infrastructure and their labs and their paradigms and their livelihoods and all of the people who work at that lab are built on what is quickly becoming an outdated paradigm, right? Like good urban planning, we have to talk about repurposing, right? There is an active market for things that are not working. And we have to understand that industry can sometimes be at odds with evolution. And we have to talk about ways to circumvent that. So talking about Parkinson's and the paradigm shift at hand. First of all, the name. The name is silly. In medicine, we've gotten away from naming things after a person. So if this were discovered today, we wouldn't have even called it Parkinson's disease. The apostrophe is annoying for those of us who write papers and grants. We can't use the apostrophe in there. It's not really even a disease. It's really more of a syndrome. And when you ask the Movement Disorder Society, the experts in Parkinson's, to define Parkinson's, when we talk about what is Parkinson's disease, they've published a manuscript, a paper saying, here's what we are calling Parkinson's. And largely what it is what it is not. It's defined by the absence of exclusion criteria, the absence of red flags. You know, you have clinically established Parkinson's if you have 2 of these 4 criteria and a whole long list of things that it isn't. But what we're running into here is a problem with this definition, because we are seeing that you can define Parkinson's a whole bunch of different ways. My next slide is going to kind of talk about this a little bit, but I want to talk about the state of the science. We don't have an imaging technique that can confirm the diagnosis of Parkinson's, right? This is the state of the science. This is an excellent, excellent review article that was just written by Carly Tanner and Jill Ostrom, summarizing kind of where are we at in Parkinson's disease. It was just published maybe a month ago. And so here, the authorities are saying you can't use imaging techniques to confirm the diagnosis of Parkinson's, and yet every single week, maybe even every day, a person comes in saying, well, I know I have Parkinson's because the DAT scan confirmed it. That's not what DAT scans do, right? It's convenient and easy for your patient, for your provider to say, oh yeah, DAT scan's positive, you have Parkinson's, be on your way. But if we're being honest and we're being true, that's not actually what a DAT scan says or does. So we have to stop dumbing it down and talking about how nuanced this is. Because the truth is, right now, we define Parkinson's on autopsy. That is the official way that we diagnose Parkinson's, which is absolutely not useful to those of you living with Parkinson's, right? It's completely useless. DAT scans don't really cut it. Skin biopsies are available. We can define Parkinson's by what the provider can observe. We can define it by what the patient experiences. We can define it by how well you respond to levodopa. We can define it by whether or not you get levodopa side effects. We have dogs that have been trained to smell Parkinson's, loss of smell, acting out your dreams, heart rate variability measures. There are a lot of very exciting tools being developed right now to get to people early and to find who has Parkinson's. My frustration, in what you should be frustrated by, is depending on which of these diagnostic criteria we use, some of you are going to have Parkinson's or not, right? If we shift the criteria, many of you will move from, oh, I don't have Parkinson's to I do. Oh, I do have Parkinson's to I don't, depending on how we define it. There are a lot of people where the dogs say yes, but the DAT scan says no, or the skin biopsy says yes, but the patient doesn't have any symptoms. Right? So as soon as you start saying, here's how we are defining Parkinson's, you include some people and leave some people out, and that makes it really difficult. Back to this fabulous review article. The other thing I want to point out is that the state of the science, we are 200 years into Parkinson's disease, and where we are at right now is there is no therapy that has been proved to slow progression. That's where we're at. This is the state of the science, 200 plus years in. We can't get to it early, and we can't slow it down. As I said, Parkinson's isn't really a disease, it's more of a syndrome. A disease is really something that has a known cause and a distinctive group of symptoms. That's not Parkinson's. We don't have a known cause, and we certainly don't have a distinctive group of symptoms. There's a tremendous amount of diversity. So if we're really talking about it, Parkinson's disease, it really should be more of Parkinson's syndrome is probably more accurate. And so this is just something I threw together. I wrote blah, blah, blah. These are just examples. I don't know what goes into making up the Parkinson's syndrome, but I really do think that we need to start talking about this as something that is dynamic and something that is modifiable and something that is changeable. Again, I'm not saying I have the answer. I'm not saying that my model is the one that we should use, but I'm saying that the old model isn't working. And so I'm going to throw out some ideas here. Every one of you obviously needs to take responsibility. I think you know that. I don't know that everybody implements that. I really need patients to feel like they are the boss. They are the driver's seat. Before you walk into your physician's office, you should be repeating the mantra, they are working for me. Right? Like you are going to your physicians, to your physical therapist, to your neurologist, to get their opinion about what your next step should be. It is up to you to decide what you do with that information. How do you build your team? Whose information do you listen to? Do you go all in? Do you put a toe in the water first? But I want each of you to think about what it would mean for you to take more control of the situation, be more authoritative in your approach here. So what I would like to do is start moving into how we engage with our providers. I think it would be very, very, very telling if you were to walk into your Parkinson's providers and ask 3 questions. Do you think there are things a person can do to slow progression? Do you think it's possible to stop progression? And do you think reversal is possible? I don't think that those are unreasonable questions for a person with Parkinson's to ask their diagnosing provider or their provider. Can I slow it? Can I stop it? And is it reversible? What I'm saying is if you have a provider who tells you no, there's nothing a person can do to slow, stop, or reverse this disease, you have a really big problem. If your provider is showing up at work thinking to themselves, there is nothing I can do that's going to change this person's course of demise. They're just going to slowly get worse and worse and worse. And my only role in their life is to help them hide their symptoms while they degenerate. You've got a really big problem. You might have an excellent defensive line, but you have a horrible offensive strategy. So I kind of think of it as an algorithm, right? And I do think of it as offense and defense. If you ask your provider, do you think it's possible to slow, stop, or reverse Parkinson's? My clinic is, yeah, let me show you how. Let's do a bunch of lab work. Let's talk about what foods you should eat, what supplements you should take, what kind of exercise. Let's chart your progression over time. Here's what we need to do to slow progression. In a lot of other clinics, the opinion is, no, I don't think there's anything we can do to slow it, but let me try to improve your quality of life as much as we can while you go downhill. I'm not saying that's a bad approach. We need good defense. I want you to hide as many of your symptoms as you can with dopamine and whatever other tools you have to hide your symptoms. I am a huge advocate of symptom management. I want you to have a strong defensive line. What is mind-blowing to me is that we are 200 years in and little to no attention has gone into the offensive strategy. It is profound to me that your doctors are not routinely saying, hey, there's a whole bunch of research suggesting that one might be able to modify their progression. Jury's still out, but here's what the emerging evidence is looking like. So the current system as it exists, and this isn't a dig on the system, I'm just saying it's old and outdated and needs to change, is purely palliative. As you get worse, we try to improve your comfort as things go downhill. It is purely targeting comfort and symptom reduction. We're not doing anything to change the course of the disease. That's what I'm here to change. I happen to be a naturopathic doctor. There are functional medicine docs. There are all kinds of other doctors who do something similar to what I do. But I just wanted to kind of give you a taste on what a different life experience it is to work with two different sorts of paradigms. In the conventional paradigm, the goal is to improve quality of life. We treat symptoms while the degenerative process kind of brings you down. The thinking is Parkinson's is irreversible and progressive, and the opinion is disease-modifying therapies don't exist. They have all kinds of tools in their toolbox, pharmaceutical tools, surgical tools, PT, OT, social work, and we have all different tools for treating symptoms over here in the conventional paradigm. In the alternative paradigm, this integrative one, there's kind of this idea that something that has been happening in your life helped get you here in the first place. Are you being exposed to environmental contaminants? Do you have nutritional deficiencies? Do you have inflammation? Do you have high blood sugar? We counsel on things like diet and exercise and social health. The commonly held beliefs are this idea that correcting abnormal labs is likely to help you, and changing your lifestyle can improve outcomes over time. And we have similar tools in the toolbox. We also use pharmaceuticals and surgery, but we also rely on nutraceuticals and lab tests and counseling and all kinds of stuff like that. So we have a long list of problems. I'm going to go into these in more detail over the next couple slides, but we don't have a good outcome measure for tracking progression. We don't know how to get to people early. Even if we did, we don't have a good way of tracking their progression over time. And there's no good reason to track progression over time as long as everyone always gets worse anyway. By the time we get to it, we're getting to it late. People have had it for 10 or 20 years. The patient experience of the disease does not often correlate with what providers can see. We spend ridiculous amounts of money studying animal models of Parkinson's, but animal models don't actually progress and don't translate well over to humans, so that poses a problem. We do a lot of really good epidemiologic work saying, hey, look, the more coffee you drink and exercise you do, it decreases your risk of Parkinson's. Hey, look, the more milk you drink and cheese you eat increases your risk of Parkinson's. We know that. We have dozens studies that say that, but we're not using it. Like no primary care provider is telling their patients, hey, you might want to lay off the dairy because it's increasing your risk of Parkinson's. So we have data that we're not using. There's a bunch of variety in the types of symptoms a person has, which makes it really hard to study. And ultimately, a lot of the studies that we do not enroll the patients we're trying to serve. Basically, most, if not the vast majority of studies enroll well-educated, higher socioeconomic people that live in urban centers near hospitals and universities where they can get to these research studies. We don't get a lot of poor people. We don't get people living in rural villages. We don't get a lot of people with low education. And so the people that we're studying aren't necessarily reflective of the population. So we're caught in this loop. To the left, we don't have a way to get to people early, even if we could. We don't know how to slow their progression, and we don't actually even have a way to measure progression. So caught in this loop, what I did is tried to tackle all three of these at once. What can we do to improve the overall system? So as I said, we're getting to it late. By the time a person has been diagnosed, they've already had Parkinson's for a decade or two. What we are seeing when you walk into the office with your very, very early complaints is the late stage downstream consequence of a problem that started decades ago. We don't know if if anything can even be done at this point. Think of Parkinson's as a snowball coming down the hill, getting bigger and bigger and bigger as it rolls downhill. Once you're a decade or two in, is the snowball too big and too unruly to actually be slowable? Is that a fatal flaw in our approach here? Other problems that we have are that motor symptoms are a huge distraction. I'm going to show you some really interesting figures in a minute showing that, tremor gets all the attention, but it is not the biggest predictor of progression. And same with alpha-synuclein, I think, has been a distraction. So I'm not going to spend a lot of time talking about why the old outcome measures don't work, but I will just say what we consider kind of the best measure of Parkinson's progression has been the UPDRS, or now the MDS version of the UPDRS. The problem is it has a floor effect, which means you actually have to be a certain amount of symptomatic to have this be a useful test. In the first couple of years, when you don't have a lot of motor symptoms, this actually isn't a useful test. Whether or not you score a 5 or a 20 or a 15 or a 30 doesn't actually mean much, right? Symptoms fluctuate a lot over the course of the day, and the nature of how it's scored means it's pretty crude. You have to have a 20% improvement just to be able to get a movement in notch. Hoehn-Yahr is even worse. It takes years to move between phases. And so it's really hard to use these quote unquote gold standard measures are not sensitive enough to be used in research. Here's a perfect example. This was one of the first studies I did on intranasal glutathione, and we used the MDS-UPDRS as an outcome measure for tracking Parkinson's progression. And there was one question on the UPDRS on handwriting, and this person's score did not change. They had a 2 out of 4 on every single one of their scores. But in their journal, not only are they telling us any notable change in your Parkinson's symptoms? Yeah, my handwriting's better. My handwriting's better. My handwriting's better. Over the course of a week, this person is telling us, I can see my handwriting getting better since I've been on this study. I objectively can see their handwriting getting better over the week on the study. Yet using the UPDRS tool, there was no change in this person's score. This person's improvement went completely undetected using the UPDRS. That's a problem for all of the researchers and all of the patients, depending on researchers, to do these studies. Statistically, this is kind of what Parkinson's progression of symptoms looks like. When we follow people over 5 or 6 years, we kind of see there's a wave of how Parkinson's disease progresses. The part I want to point out to you is the only one that doesn't get really worse over time is tremor. And this largely might be a result of the success of dopaminergic therapies. It's not getting worse over time because we have good medicines to hide it. That's great. I don't think that's a failure. I think this is a success. I want every other symptom to have that flat of a progressive curve. This is great. This is good news. But for a statistician or a researcher trying to find out, hey, does this medicine help this patient? Tremor is the dumbest symptom to look at. It's not getting worse over time the way the other ones are. What we should really be looking at are handwriting or some of these other ones that have very clear slopes. We've known this since the beginning. We published this paper, 2017, I think, and we saw every single symptom on the Parkinson's, on the PRO-PD scale I'm going to talk to you about in a minute, gets worse over time, except tremor and nausea. Those are the only two. So again, tremor gets all the attention, but it is the least useful outcome measure for us to study. So when we talk about Parkinson's symptoms, the point I'm trying to make here is that we're not even talking about the same disease, right? When you ask patients to describe, hey, what is Parkinson's to you? Describe the symptoms of Parkinson's. 80 to 85% of you say fatigue, handwriting problems, and loss of smell are a problem. 70 to 80% of you say memory impairment, muscle pain, daytime sleepiness, slowness, tremor, sexual impairment, balance problems, urinary dysfunction, stooped posture. If you ask your neurologist what are the symptoms of Parkinson's, they're not actually going to list those same things that most of you are complaining about. They're more likely to focus on the motor symptoms that they were cardinal symptoms. Slowness, rigidity, tremor, posture are kind of the cardinal symptoms they were taught. But that's not what you all are experiencing. And to make it even more complicated, what industry is working on, dopaminergic meds are the easiest to get through, in terms of bringing a new Parkinson's drug to market. Dopamine is kind of the easiest path forward. And so I'm just concerned that what industry is working on, what patients are experiencing, and what physicians are describing Parkinson's as are not even the same set of goals, right? And I really do think that we have been defining Parkinson's all these years by what the provider can see, not by what the patient experiences. And I think that has to change. I really think we need to reclaim the definition of Parkinson's, at least in addition to whatever the researchers are saying. In addition to that, patients need to say, we are defining it by our set of symptoms. So if we were to build the ideal outcome measure, it would correlate with patient's sense of well-being and disease, which makes it clinically relevant. It would not fluctuate over the course of a day. Patients could enter the data directly so that you don't have to pay somebody to transfer it from papers over to computer. It would not require a trained healthcare professional like the UPDRS does. It would capture both motor and non-motor symptoms. It would allow us to see, after you answer it, which symptoms are good, which symptoms are bad, so that we know where the changes are taking place. It would be quick, simple, and easy, and it would correlate with existing measures. So I set out to try and work backwards from that list and build a currency that met that goal. It is absolutely easier to ask forgiveness than permission, right? There is no way in a million years in 2010, as a newbie to the Parkinson's field, a naturopathic doctor, not a neurologist, not a movement disorder specialist, I could have gone to some of the authority figures and said, hey, let me build a scale that works in a way that your historical scales have not been working. Nobody would have let me do it. They wouldn't have trusted me to do it. And so I didn't ask for permission. I just did it. I had already had probably 100 patients at this point with Parkinson's, and I was listening to them about their symptoms. So we built this scale called the PRO-PD, and what it is 35 symptoms of Parkinson's disease, and there's a slider bar, and we ask for each symptom, please rate the severity of your symptoms on average over the last 7 days, very quickly. So rising from a seated position, like if it's really bad, you slide to the right. If it's not bad at all, you slide to the left. It takes about 5 minutes to get your score. And what we see is the higher your Parkinson's score, the worse your quality of life. The worse your quality of life, the worse your mental health, the worse your physical health, and the worse your social satisfaction. In fact, we have shown now in a couple different studies that it correlates with existing measures of Parkinson's severity, all the old ones. And then last year, the independent group in Sweden, independent of me, translated the scale. They used it in their own population-based study, and they independently validated the scale and said the PRO-PD was found reliable and valid for monitoring Parkinson's symptoms in outpatients. So now you do all have an outcome measure that works. You don't need to go to the doctor. You can do it at home, and you do have a way of tracking Parkinson's progression. And the part about it that I like, even if you disagree with the list of variables we've chosen or how we've set up the scale or what we've used as a tether, what I will say is the one thing that we can all agree on is if you score a 0, everybody is happy. If you go through this list and say, for these 35 symptoms, I don't have any dyskinesia, I don't have any tremor, I don't have any balance problems, I have no temperature dysregulation, I don't get dizzy when I stand up, my eyes work great, I sleep like a baby. If you can go through this list and say, I don't have any of the symptoms of Parkinson's, your score is going to be a 0 and we're all happy. It doesn't matter if we're talking patient, researcher, or doctor. We can all agree the closer we get to 0, the better we're doing, right? And so that's what I was after. And it turns out patients actually know if they are doing well or not. Mind-blowing to know that you are just as good, if not better, at knowing how bad your symptoms are, as opposed to your provider knowing how bad your symptoms are. It turns out that you are just as good, if not better, at knowing the severity of your disease than any tool, machine, test, biomarker your provider has. It turns out if we simply just ask the patients, how are you? Add up all their points, they're really, really, really good at telling us, right? And I want to show you, oops. So what we can do is we can kind of plot all these down, and there are all different ways to slice this and look at these data, but all of the green dots on the left are real people with Parkinson's. And you can see there's a tremendous amount of what we call heterogeneity, diversity. Some people are in really, really, really bad shape right after diagnosis. Other people are incredibly good shape 20 years after diagnosis. When we flatten the line and make estimates, what we see is the state of the science in our cohort. People are getting about 10 good years before their quality of life goes from good to fair. Even if we slice the data a little different way, we're seeing kind of the same thing. The curve is not necessarily linear, but we see the state of the science right now in 2024 is people are getting about 10 good years. And what I think we should really be setting as a goal is, what do we need to do as a country, as a clinic, as a doctor, as a patient, to reduce the slope of this line? And symptoms fluctuate a lot. This isn't a perfect measure. Using this measure following people over 6 years, there is a tremendous amount of diversity. It goes up and down. Things got really bad for this person for a minute. Did they get in a car accident? Did they fall down the stairs? What happened here? Did they start meds? Right? This is not a straight line. Parkinson's symptoms fluctuate a lot, and to the patient, it can feel a little bit like whack-a-mole. I don't know if I'm better or worse than 6 months ago. I'm sleeping well, but now I'm constipated, right? Like, things change a lot. And so it's really hard to keep tabs on exactly how things are progressing or reversing. And so this scale kind of helps, but I want to show you, with this much diversity, I mean, you all know that symptoms fluctuate over the course of the day, over the course of the week, over the course of the month. Here, we're seeing that they fluctuate a lot year to year. The point here is, if anyone, myself, takes a snapshot, a slice of the pie, if your neurologist sees you for 5 to 10 minutes and has you do an exam, my point is, any slice, any snapshot of how you are at any point in time isn't very good because of all of the background fluctuations. This whole approach where we take a slice of the pie and we just try to drown out the background noise by enrolling 3,000 people isn't working. I think we need to find new tools that do a better job with the scales. For those of you who want your Pro-PD score and want to start tracking it, I want to let you all know it's free. I don't make any money off of it. It is free on iOS and Android. And all of you can be tracking your own scores, generating your own report, and seeing what's getting better and what's getting worse. So now that we've built a currency, we want to identify the people who are doing unusually well and describe what they are doing. Out of the gate, meds. I know that I do integrative and alternative medicine type stuff, but levodopa is a nutritional deficiency. Just like an insulin-dependent diabetic can't make enough of their own insulin and they need to supply it exogenously, so do people with Parkinson's not make enough dopamine and they need to supply it exogenously. You have a dopamine deficiency syndrome, right? I do think you need to take dopamine. For all of you out there who may be nervous about starting meds, I think it is absolutely integral in the package of people doing best. So here we can see, after a person goes from not on levodopa to the first 6 months after they start levodopa, not a single symptom gets worse. What we've done is set everybody to 0. And all of these symptoms under the blue line are the ones that get statistically better in the 6 months following starting levodopa. I want to point out that tremor does get a little bit better, right? But that's not what improves nearly as much. As the symptoms that improve the most when a person starts dopamine are anxiety, muscle pain, sleep, and apathy. we don't really think of those as dopamine responses symptoms, but according to our study, when we look at people's symptoms prior to them starting levodopa, and then they start levodopa, what symptoms change? They have less anxiety, muscle pain, sleep problems, and apathy. That's great. So so what else makes meds work better? DBS, we can see some improvement. Interestingly, the improvement improves over time, right? People following DBS are better at 12 months than they were at 6, and it looks like they're even better at 24 months than they are at 12. So that's exciting to be able to see that using conventional therapies, we do see that the pro-PD improves. But I took it a step further. I'm not just looking at conventional therapies. We know which foods are associated with faster and slower Parkinson's progression, right? We know which supplements are associated with faster and slower progression, right? And what we're looking at here is we surveyed 1,100 people with Parkinson's, and we said, check any of the supplements that you have taken consistently for at least the last 6 months. And we compared 55-year-old men to other 55-year-old men in the same income bracket, same level of education, diagnosed at the same time. And the people taking glutathione were on average 240 points less symptomatic than the people not taking glutathione. This isn't a shopping list. I don't want you to go and take all of these things, but I do want you to ask, is my doctor not talking to me about some of these things? Should I be taking some of these things? Are there a couple things on here that are worth the money and the science supports them? They have minimal risk and potential value. We can see that lonely people are much more symptomatic. People who say, I have a lot of friends, are almost 40 or 50% less symptomatic than lonely people. The more you exercise, the fewer your symptoms. And we can actually even see where we see the most symptomatic improvement. We can see which symptoms are most improved in people who do more exercise, right? So these are all different ways that we can start to use this scale to start to identify who are the successful people and what are they doing differently. So this is kind of the paradigm that I'm working under, where it's not, it's complicated, right? It's multifaceted, it's multimodal. We'll talk about this body in the center as the person with Parkinson's, and all of these arms being the things that contribute to how well a person with Parkinson's does. I don't think anybody on here is surprised to learn that there are environmental toxicants that might contribute to Parkinson's. I don't think anybody on here is surprised to learn that stress might contribute to Parkinson's, or that social health might contribute to Parkinson's, or that diet might contribute to Parkinson's. Nothing on here is really mind-blowing, and yet it is mind-blowing to me that we are 200 years in and we aren't using this type of model, something that is so obvious and so intuitive and so true to so many. We're not putting it to use. We're not putting it into practice. Why aren't we building a model like this where we can check in and say, all right, let's make sure you're covering all of these bases to the best of your ability to get the best possible outcome measure we can. So this is me just kind of playing around with a paradigm in my own head to help me think about how I want to move the field forward. And I think it's easy to get lost in the weeds if you're not thinking about it from a big picture perspective. And so I'm seeing this as kind of a horizontal integrated program where we have early detection, monitoring, assessment, and disease modification. And they all have to work together for us to have a new approach. So starting with early detection, I am not the only person doing this, right? There are smell tests that you can do. Your physician could ask, are you constipated? Do you act out your dreams? We could have public health campaigns. There are a lot of sleep doctors could be kind of identifying people with REM sleep behavior disorder and sending them to the neuroclinics. I went to a conference earlier this year and I was really surprised at the question on the table, probably 300 movement disorder docs in the room. The question on the table was, if a patient is diagnosed with REM sleep behavior disorder, should we tell them that they are likely to go on to get Parkinson's? And the number of doctors who said no was mind-blowing to me. Like their opinion was, why stress them out? There's nothing that they can do. Let them go put their head in the sand for a few more years, live a good life. And if they get Parkinson's, they get Parkinson's, and we'll tell them then. That to me is mind-blowing, because that is such a critical, pivotal time to make a difference. And this is why early detection matters. Again, we're back to this pro-PD scale. The black solid line is real, true data. This line starting right here, if we were to take a newly diagnosed person and reduce the slope of their progression by 50%, that means that, 25 years from now, instead of your quality of life being poor, now it's fair. I'll take it. It's an improvement, a 50% improvement in slope starting at the day of diagnosis. Great. Better than what we have. But look at what would happen if we could actually get to you when this disease started. Right? Like, what if we could find you at the beginning of this before you had any symptoms and get you that same 50% improvement? If the average person gets diagnosed at 550, normally this person, without doing anything differently, is going to get diagnosed in 20 years. However, if we find them early, get them exercising, eating different foods, maybe taking different supplements, doing something, we're talking about 50 plus years before they are actually symptomatic enough to get a diagnosis. I mean, if we can get to people early, even a small decrease in symptoms could double their disease-free years, from 20 to 40, from 25 to 50. That's huge. These are huge, huge numbers, and we are not taking advantage of this. I don't know how much time we have. I just want to let you know I'm doing a whole bunch of things on my end to try and move this field forward. Again, I don't have all the answers. This is not publicly available, but I have 2 Italian truffle hunting dogs.
And welcome to the Park 9 testing facility. We've spent the past few months training dogs to identify the scent of Parkinson's disease. The purpose of this video is to demonstrate how we have the track set up and to show the viewer how the dogs signal a positive sample when they find it. I've circled the container with the true scent of Parkinson's disease, which I'll show briefly before bringing the dogs out for each of the rounds. In these first couple examples, all the containers are empty except for a single container that has cotton-tipped swabs from the ears of individuals with Parkinson. This is our 6-month-old Lagotto Romagnolo, Reese. Here comes our 2-year-old Lagotto Romagnolo, Coco. She fails miserably at walking the track, but has no problem identifying the correct sample.
So what if we got at 45, 50, 55, 60? What if we had people turn in dirty cotton swabs from their ears every 5 years and just had the dogs go up and down the track saying no, 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 yes, yes, no, 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 yes. It doesn't mean you have Parkinson's, but if we can identify people who have the scent of Parkinson's, this is cheap, this is fast, this is easy. Maybe they could go in for a skin biopsy. Maybe they could go in for smell testing. Maybe they could get some of their blood work done now. But this is part of my routine life. This is patients asking for me, before I go to work in the morning. I'm in my pajamas, but look at, like, the same thing.
That's from Coco. Nancy, if you know. Show me. You show me that one. What about this one? Or this one?
It's that easy. It's that easy. I mean, we have so many tools we're not using. So we talked about early detection. We talked about monitoring this Parkinson's symptom tracking app. Every one of my patients, when they get their email that says, don't forget you have a visit with Laurie tomorrow, before your visit, be sure to get your Pro-PD score, use your app to get your score. Before the patient comes in, I can see, are they better or worse than they were the last time I saw them? How have they been doing over time? What symptoms should we be prioritizing? And this is a way for you to track your, hey, I'm starting a new medicine. I want to see if I can measure improvement. I'm starting a new diet. I want to see if it makes a difference in my symptoms. There are lots of ways to do this. There's a video online how to use the Parkinson's symptom tracking app to get your score. I think this is a very useful 20-minute video. But all of my patients for the last 10 years, I can tell you the rate at which they are progressing. I can tell you, are they getting better? Are they staying the same or getting worse? Because we have been tracking their symptoms every step of the way. And it's not just me who's using it. Certainly, there are some industry-sponsored studies that are using the ProPD. This is one of my favorites. There's a group of women, I think there are about 12 of them, and they get to 9 of them, I guess, 9, and they get together once a month. They call themselves this little secret society mastermind group, but they get together and quarterly, they all pitch in, they all submit their scores, and what they're doing is working together like a team to see, can we as a team bring our whole score down? Right? It's fun. It's fun. Your gyms that have these weight loss challenges, right? Hey, in the month of May, we're going to see who can lose the most weight. Why don't we do things like that in the month of April? It's Parkinson's Awareness Month. Let's see who can improve their ProPD score the most in a month. Let's see who can change their diet the most in a month. Let's see who can improve their heart rate variability the most in a month. Let's see who can have the greatest improvement in their sleep score over the course of a month. Let's get a little competitive. Let's find new ways to have a little, I don't want to say fun, but have a little fun trying to turn the ship around. Assessments are a huge can of worms. It's mind-blowing to me that conventional neurology does not acknowledge biochemistry. There are so many lab tests that have been linked to better and worse Parkinson's outcomes. I won't even see a new patient for a very first initial office call in my clinic if they don't do a set of labs before they come in. My hands are tied. I can't help them if I don't know if they have a B12 deficiency. I can't help them if I don't know if they're inflamed or their blood sugar is too high. There are things I need to know to be able to tell you how best to help you, right? My answer is not just throw dopamine at everybody. It's get to the bottom of what's wrong and try and fix it. So other doctors may have a different panel, but what I do in my clinic costs $379, and I get more than 50 pieces of information, all of which contribute to how I treat the patient. So if any of you can talk your doctors into doing something similar, I wrote down the panel that I use, and I've taught classes on my Parkinson school about how to interpret them and use them. But just to tease you a little bit and give you a little taste, you know, when the lab comes out and it says, say your doctor orders a B12, the B12 reference range says 200 to 900. And so a person who has a 500 says, oh, I look pretty good compared to the reference range. I'm right in the middle. But when we come and look at B12 levels in a person with Parkinson's, this is in the Parkinson's Journal, and we look at B12 reference ranges in Parkinson's people, and we look at B12 levels early in the disease. If you come to the table with a B12 level less than 587, which is absolutely normal, it's actually medium, good, hearty, normal level. If you are 580, there is a 0% chance that you do not have dementia by year 10, is what I read from this study. Just having a B12 level up over 600 is enough to get you into the 70% chance of being dementia-free category. For the life of me, I can't figure out why all doctors, the day of diagnosis, don't test people for B12. I mean, even if we didn't test you, we said just take it. The very, very, very fanciest, highest dose, best absorbed form of B12 that I can find costs $180 a year. Do you know the cost of dementia? I looked it up. In the United States, a memory care facility is $83,000 to $94,000 per year. Like, we are yet not being smart about this at all in terms of where can we find opportunities for prevention for at least some of the parts of this disease that are so debilitating. Vitamin D is another big one. There are dozens and dozens, maybe hundreds of studies now that show that people with Parkinson's tend to have lower vitamin D. That vitamin D is neuroprotective. The lower your vitamin D, the worse your Parkinson's symptoms, the greater your fall risk, your muscle weakness, your constipation, your bone risk. And then just last week, a study came out, a really, really well done study based on the NHANES study that we do here in the US. And what they showed is that among people with Parkinson's disease, people who had a B12 or a vitamin D level between 75 and 100 nanomoles per liter had a better survival curve. right? So in the United States, that is 30 to 40 nanograms per mil. In Europe, it is 75 to 100 nanomoles per liter. We use different units, but still, this is a lot lower than what I've been recommending. And what they showed was there's a sweet spot. It's vitamin D is a U-shaped curve. Too little, you have a problem. Too much, you have a problem. So have I don't know if I'm probably going to bring down my patients. The advice I have been giving to patients has been 60 to 80 over the years. Based on this new research, I might bring it down a notch and be a little more conservative in terms of the vitamin D levels I'm chasing. Either way, you and your neurologist should be talking about this. Well, hey, I have Parkinson's. What's my vitamin D level? Should I increase? Should I decrease based on these new data? Why are we doing these studies if we're not using them in clinic? Here's another one, a high sensitivity CRP test. It stands for C-reactive protein. It's a measure of systemic inflammation. The reference range is less than 1. Everything is fine. However, if we look in Parkinson's disease, that's not actually true. The standards are a little bit higher. 0.8 is the magic number. Again, we take people early in the disease, measure their degree of inflammation. People who are more than 0.8 inflamed have about a 45% chance of still being alive 10 years later. This is not death from Parkinson's. It's all-cause mortality, broken hips, car accidents, heart attacks, strokes. But Parkinson's patients with a CRP level greater than 0.8 are 45% likely to be alive in 10 years, whereas opposed to people who are less than 0.8, 70% likely to still be alive in 10 years. That's huge. I think it's an $8 test. Do you know how easy it is to reduce a person's degree of inflammation? We start chipping away at it. If they are inflamed, we start with diet. We go to the dentist. We look to see if they have an H. pylori infection. 9 times out of 10, it is pretty easy to get an inflamed person down to not inflamed in a matter of months. The problem is most of you don't know whether or not you're walking around with chronic low-level inflammation because nobody's testing it. So when we have all these data, here, this is a typical visit, my first visit with a patient. Here's a person who has severe B12 deficiency from all different angles. They're inflamed, their homocysteine is high. This is what I'm doing with my patients in the first visit. And I don't know that my approach is right, but we need to have more doctors taking more radical approaches because the old system isn't working. Hair tests are a hot topic because most doctors roll their eyes. We use hair tests for history. When we find Vikings, we do a hair test to find out what they've been eating. When somebody gets poisoned, we do a hair test to figure out which radioactive element they've been given. We use hair tests for crime scenes, for historical purposes, and even for medical purposes. But because doctors in day-to-day routine clinical practice don't use hair tests, they are often dismissed. What I want to tell you is I am definitely seeing some patterns in hair that are unique to people with Parkinson's. This is a bell curve. The way a bell curve should work is that everything should be in the green zone, 1 standard deviation from the mean. Most people, quote unquote, normal people, half of their lines will be to the right, half will be to the left, but they'll all be in the center zone, meaning they're quite normal. My master's work is on lithium deficiency, and hair is the only place to measure lithium, which is why I started doing hair tests in the first place. But I started doing hair tests so that I could get my data on lithium, but I very quickly started to realize people with Parkinson's have a very different problem. They are low in minerals across the board. I mean, this is really low. You have to be in the bottom 2.5% of people ever tested to have your line reach all the way into the red zone. That's 3 standard deviations below the mean. Most of my patients on most days, I'd say 90% of my patients look like they are deficient in all minerals. And it's really fun to get their mineral status back up and watch them get better. So again, just in terms of tools we are using, are we even looking under the right lamppost? I mean, everyone's focus is on alpha-synuclein. What about inflammation? What about vitamin D? What about B12? What about, and then in terms of how we package disease modification, I don't think a pill is going to be the answer. I don't think there is going to be one pill that solves this problem. I think this is a complex disorder. We all got here in 100 different ways. And I think that it's going to be a little more complicated than that. But I do think we need to get creative in how we deliver medicine. Education is medicine. I believe that thoroughly. I am not taking new patients. My practice is full, but there are patients who want to learn what I'm teaching. And so I've worked really hard to try and find ways to scale education. I put a ton of effort and work into my online Parkinson school, right? This is everything I know. And I've designed this so that everything I know is on there, and any time of day, people can start diving in and finding, what should I eat? How do I make my meds not interfere with protein? What does Laurie say about B12? To the best of my ability, I have tried to make it so that my patients and anyone else who is curious has access to whatever I'm learning. But this is my attempt at a solution to the problem that there's too much information out there. We don't have enough time with you in clinic, and clinic visits are too few and far between. So what I have tried to do is scale instead of telling the same stuff to each person who comes in over and over and over like a wind-up doll, let me record myself saying it once and make it available for everybody. We're trying to package diet. I've given you this list before. We can make it available to after this, but this is kind of the point system associated with faster and slower progression for foods. But what we are struggling with is, now that we have been following people for 10 years and we know who the fast progressors and slow progressors are, what we want to know is, how can we package it? What do we need to do to get you to eat more of the good food and less of the bad food? Can we package friendship? Can we package exercise? Like we can tell you now where the fish are biting. We're not sure how to get it to you. And lastly, I want to talk about some radical new approaches to research. These data are not published, but they actually are true data. What we've been trying to do is look at, hey, based on all of these 800 variables we have been collecting data on over the last 10 years, how much does any of it matter? Right? And we have 3 different statisticians doing this from 3 different angles. So this might change a little bit, but it looks like, 10% of your overall symptom severity is defined by how many years you've had Parkinson's. Food looks like it's about 9% of it. Your social health is another 6% of it. Your income, how severe your symptoms are, is 4.5. The model changes by 4.5% when you plug in different incomes. That's kind of how we're talking about this. How much does exercise matter? And this is what we were talking about before we turned on the video, is this big unknown. I mean, this is where air pollution comes in. This is where your lab results come in. This is where the pesticides on your cucumbers comes in. There are things that genetics is not being accounted for in here. So I am not even a little teeny bit telling you I have the answer. I'm not telling you that you can go home and do a little exercise and eat some broccoli and make this all better. That's not what I'm saying. I'm saying that we are very, 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 very slowly starting to build a model where at least 40% of what we're talking about here might be more modifiable than what we've been giving it credit for. Whole systems research is really kind of what we're talking about here. What we are talking about is whether you use acupuncture or Botox for migraines, right? Like, there's no placebo. You know whether or not you're getting acupuncture or Botox, but we can still use the same pain scales, the same cost analysis, the same kind of outcome measures to find out at the end of the day who gets fewer headaches, right? Even though the approaches are radically different. This is kind of fun because really the vibe at the acupuncture office is part of the medicine compared to the vibe at whoever's giving you the Botox. The color of the walls, how you're greeted, that all is included in whole systems research. The other thing I would like to get into is comparative effectiveness research. And what we are talking about is not studying the patients, but studying the providers. Who's better, Bob, Steve, or Laurie? Which clinic is getting better results? Mayo, Beth Israel, or King's College? Philosophically, do the doctors with a functional medicine approach or Chinese medicine approach get better or worse outcomes than people doing conventional care? What about state by state or country by country? Can we compare the rate of progression in the United Kingdom versus Canada versus US? Let's get competitive. Let's see who can flatten this curve first, right? And when we pull away the veil of all these fancy terms like patient-centered, pragmatic, comparative effectiveness research, what we're actually talking about is competition between providers. And it's been really hard to find people to compete with me, let me tell you. I want to turn our attention away from the patients and what do you guys do? Is it the red pill or the blue pill? And ask, are there things that your providers are doing that are getting better results than others? Are some people beginning to figure it out, right? And so about 5 years ago in the MVP study, we started asking people, where are you getting your care? We asked them, how many vegetables do you eat? How much do you exercise? What time do you go to bed? What meds do you take? But we now also ask, what clinic do you go to and who's your doc? And it's kind of fun, right? Because now we don't need the physician's buy-in to compete. All we need you guys to do is enter the study and tell us who your doctor is, and we can do it without them even knowing. So I get that this is a loaded topic here. And I just want to say, I'm competitive. I'm absolutely competitive. I honestly don't care if I win or lose. I'm not that attached to the outcome. I love learning more than I love winning, right? If I learn that Dr. Smith down the street is getting twice as good of outcomes as I am getting, I will stop everything I'm doing right now and go study with Dr. Smith. Like, that's good. It's good for me. I get to learn. It's good for you. You get the benefit, and we can all benefit by figuring out what Dr. Smith is doing. So in my opinion, this whole paradigm, Parkinson's, isn't really about whether or not a treatment reduces alpha-synuclein. What I want to know is, does a treatment improve your quality of life and reduce your symptoms? And that's really easy to measure. When I was a teenager, my dad used to tell me every time I'd complain about gossip in town, he would always say, if you're not proud to have people talking about what you're doing, maybe you shouldn't be doing it. And, you know, as much as I don't want to admit that he's right, he's probably right, right? Like, if you're proud of who you are and what you're doing and how you're behaving, let the world talk, right? So it is hard to be subject to scrutiny, right? Like, it is really, there are some very good reasons neurologists and doctors are not likely to jump on this, right? So for people who work in underserved communities, you're going to get worse outcomes. This isn't fair. People, just because a patient has poor outcomes or an entire medical center or a region of a city is getting poor outcomes, that doesn't mean it's a bad doctor, right? They could be working, they could have trouble affording healthy food. They could be living with a lot of stress. There could be financial instability. So bad scores do not equal bad doctors. However, this approach should be good at, if we have somebody getting unusually good results, we should be able to learn from them. Before I give you some examples, I do just want to say there's a tremendous amount of North American bias. I believe over 80% of the people in our study are from the United States and Canada. For those of you who want these data to also reflect you, please join the study. Get as many people as you can to join the study. The more of you who join the study, the more accurate our data is going to be, and the more it will appeal to a global cohort, not just a US and North America-based cohort. And I will just tell you, we have the Parkinson symptom tracking app now, that ProPD app, and there are over 6,500 people now from 150 different countries. And I am telling you, it is heartbreaking to see how much worse people are doing in some parts of the world compared to others. If we just drew a rate of progression slope based on the data we have in people in different countries, the record would come to a screeching halt. It is shocking to see that as much as we are comparing about these 10 good years, oh, look at how, like, we need to do something about the fact that we only get 10 good years. There are a whole bunch of places in the world where we are not getting 10 good years. Depending on the perspective you take, we are the positive deviants, right? So I do want to say we really need more global representation. So ultimately, what we're talking about is putting our money where our mouth is. And so I'm talking about wanting to do this comparative effectiveness research. And I just want to show you, these have not been through peer review. This is unpublished data. These next couple slides are just to demonstrate feasibility. I just want to rock the boat. I want to get get people a little wound up here. But what I've done is I took, there were, I don't know, what is this, 350, 400 people in the Pacific Northwest. And I compared among people from British Columbia, Washington, Oregon, and population normals. British Columbia looks like they have more patients getting better than Washington and Oregon. And Washington has the fewest people getting worse, right? It's kind of neat. Like, just, okay, I just want to know, can we do this? Are there enough people to start to compare? Can we make some of these charts? That's kind of fun. I honed it in a little bit and looked at competition between clinics, right? Like, this is all of the local Parkinson's clinics throughout the Pacific Northwest. This person has a lot more people getting better than whoever this clinic is. This clinic stinks. I don't know what they're doing, but no one's getting better over here, right? And opposed to some of these, where are people getting worse? Why aren't we giving all clinics report cards? Like, they should know if they're doing better or worse than the clinic down the street. How can we get better if we don't have an assessment tool that measures our progression? I'm excited about this. I looked at the patients in my clinic compared to the Parkinson's Centers of Excellence, right? What this shows is we have more people getting better and fewer people getting worse than what you would expect in the general population or at the Parkinson's Disease Centers of Excellence. I don't know if these data are true, right? I am sure a lot of my patients get their care at a center of excellence, right? Maybe once we adjust for money, this all goes up in smoke. But there is enough here to say prospectively, let's do a head-to-head trial. I will totally take 100 new patients and do a head-to-head competition to see which doctor can we get better results than clinic B or C. So I wanted to start doing that in my own clinic. So as I said, every single person before they come in, I ask them to get a score. And what I wanted to know is, we know that this line that goes through the center of the graph represents the average rate of Parkinson's progression. See, I have people coming in all month, and I wanted to know, normal would be 50% of my patients better than average and 50% of them worse than average. I wanted to know, how am I doing compared to that expectation? Turns out we had 87% of my patients for the month. We looked at, for the month of May 1st to May 31st, did not skip anybody. Every single person who came in the office, we asked them to rate their symptoms. And then at the end of the month, we looked to see, was their little dot below or above the line. 87% of our patients are reporting that they are better than average. Great, I'll take it. Maybe they came in better than average though. Maybe only the people doing really well walked in our front door. So it's not really fair for me to take credit for this. I just wanted to see, how are my patients doing? So what I did is I took every single one of their plots over time. Some of these go back to 2017, they go back a ways. Some are only a year or two old, but some go back quite a ways. And so what I did is I took everybody's story, their Parkinson's story that they tell, and I put people in two categories. Did they get worse over time? And again, I called this worse over time because their end number was a little bit worse than their starting number. I would argue even these people who are worse over time are fairly stable, but still, I counted this as worse over time, just to play by the rules. And I put people who were getting better, where their end score was better than their first score. And I'm very proud to say, in my clinic over 1 month, and it might be different if we looked at a different month, but in that 1 month, 54% of my patients are reporting fewer symptoms than when we started working together. Right? It is my reality. When I go to work in the day, it is a normal statement to say, I would estimate half of patients are fairly easily able to stabilize Parkinson's progression, if not see some improvement. When I talk to neurologists, it is just out of the gate. You can't reverse Parkinson's. You can't improve symptoms. It only gets worse over time. And I'm like, well, I don't know what scales you're using or what tools you're using, but that's not my experience. I see people getting better all the time. It's not that rare to have somebody express improvement. You know, here's somebody who went from unable to walk without a walker to kayaking across Alaska after starting B12 shots. I mean, it's really fun when you can see this improvement. And so I have blocked out, because these are unpublished data and I do intend to publish these, you'll never know which of these lines represent the average rate of progression in Sweden in our MVP study and in our clinic. But I do want to just show that we are beginning to see that you can see improvement over time. Maybe you need different tools, maybe you need a different scale, but I do not think we are any longer at a place where we can say progression is inevitable. I simply don't think that's true anymore. It could be chance. If we looked at this a different month, we would get different results. It could be that my asking people to track is therapeutic, in which case any other doctor should be able to start asking their patient to track and also see a similar improvement over time. It could be that the benefit has nothing to do with my medicine, but the type of patient I see. I see a more well-informed, more educated, more empowered patient. So it could just be the people who walk in my front door are a whole different type of person. It could be that I am just one big placebo. The fact that I actually believe that it is possible to make a difference is infectious, and you start becoming delusional about how you rate your scale, and you think, I don't have a tremor, right? You know, like it could be that my placebo is brainwashing you and making you think you have fewer symptoms than you actually have. That's possible. Or there's something that we're doing that's working. Maybe me getting on your case about exercise, or telling you to take glutathione, or eat your Brussels sprouts, or stop eating dairy, or go to bed early, or go make some friends, or join a pickleball team. Like, I don't know which of those are working, but it could be that actually some of that is working. So I am actively seeking competitors, and all of you, if you join this MVP study, you can help us get a lot more data. You can help us kind of find the people who are getting it right and doing it best. Here's the link to the study website, and I just need to stress more than anything that any one of you by yourself is not going to know if you start eating more vegetables or make a new friend, whether or not that is ultimately shaping your journey. But there truly is power in numbers, big data. If all of you do what you're going to do anyway, and twice a year log on and tell us what you're doing, we can write code that tells you, hey, look at this. Everybody who started doing what Mark did started getting better, right? That's what the statisticians are working on. And the more people who join, the more granular and capable the data becomes. All right, so with that, I will ask you to all go grab your jersey.
I think we all know which one we want. Laurie, thank you very much for a very thought-provoking presentation and for really challenging the paradigm that has been in place for more than 200 years and clearly hasn't really worked. I think your audience is really very passionate about what you're doing, and it's always refreshing and thought-provoking in a positive way to hear you present to us. I would suggest that we maybe spend no more than 45 minutes for the questions and answers, to not go totally crazy with the time. I know, Laurie, you're very familiar with Zoom, so I can either read you the questions, or if you want to read them yourself, it is entirely up to you.
What can you tell us about being 20 years out? Well, I'll just tell you that we need a lot more patients who have had Parkinson's 10 years or more. I have two really, really, really good statisticians right now working with the data, and both of them are only able to tell us with confidence what's happening in the first 10 years. We have lots of data. Almost everybody in our 3,500 person data set, I think 80% of them were all diagnosed in the last 10 years. So if you want me to be able to talk to you about people who have had this 10 to 20 years, 20 to 30 years, 30 to 40 years, we need you to recruit all of your friends who are more than a decade in, so I can give you better data on that.
There's a question from Carla that I thought would be interesting, although I do not recommend what she's suggesting there, but she's asking whether, in your experience, can some people with Parkinson's stay off levodopa indefinitely through diet and exercise interventions? And is it a good thing to try to do?
No, it's not. It's not even a little teeny bit. I think there are two things. One, as a diagnostic tool, it's really, really, really helpful for you and your providers just to know is whatever this clinical syndrome you're presenting with levodopa responsive, right? Because if it isn't levodopa responsive, then we have a whole bunch of work we have to do trying to figure out what's causing it. If it is levodopa responsive, then why wouldn't you take this really cheap, readily available amino acid with very minimal side effects to improve your quality of life, right? And so I know there are a bunch of online concerns about fear of levodopa. And so in the online Parkinson school, I've made it free. There's a class on dopamine repletion. I go into really, really great, excruciating detail, kind of at every one of the rumors that are in circulation about, oh, if you start taking it, your body won't make your own, or all of the rumors that are out there. But the short answer is, if I were diagnosed with Parkinson's today, I would start some form of dopamine repletion real quickly. And I might start with Mucuna or Rasagiline or one of the more mild drugs that doesn't have the roller coaster of ups and downs. But I would very, very, very quickly work to get some dopamine on board, because remember, even though you might be able to tough it out, your brain and body have been thirsty for years. And so even though you think, oh, my tremor's not that bad, my motor symptoms aren't that bad, I just showed you when you start dopamine, your apathy improves, your sleep improves, that kink in your neck sometimes gets better. People don't realize how much better they feel when they actually put gas back in the tank. Dopamine is not so much a pharmaceutical medicine as it is replacing a orthomolecule that belongs in the system. It's more like correcting a nutritional deficiency than it is taking a medicine, in my opinion.
So a bit further on, thank you very much for this, Laurie. Jack Deep from Dopamine Warriors has been using ProPD since his diagnosis in 2021, which is great. He's complimenting the system and saying it's simple to use and good tool to keep track of progression. He has a question about the fact that he is tremor dominant. And I know you touched on the topic of tremor, and he's asking whether you have information about the progression of tremor over a period of time for those of us that are tremor dominant.
Yeah, it is in every study that we've looked, it doesn't seem to get much worse over time. Like the intensity of your tremor does not become more and more and more problematic. For most people, it stays low level, 30% annoying for most of the Parkinson's journey. So there are other studies that say that people with a tremor might actually progress a little more favorably, but we don't know that for sure. But other people's research suggests that it's not necessarily a bad thing to have a tremor. It might actually even be a good thing.
So thank you for this, Laurie. So this is not a question, it's more a comment, but I just thought it was worth making it known to everyone. Shaky Lady is saying that she has asked her group when do people feel their best, and all said when they are with their grandkids. And I just wanted to use that as an example of the impact of social activities, which I think is very often not talked about by the movement disorder specialist.
Yeah. Yeah.
Someone anonymously is asking, on average, how much do your clients cut progression by in comparison to normal progression?
Well, I don't know, which is why we did that study. I wanted to know, which is why I took every single person who came in May, and they do better than I would have guessed they did. I set out to see if I could slow the rate of progression by 50%. I thought if my patients were not progressing at least half as fast as general population, I was wasting their time and money. And I can tell you we're getting better results than that. And so now we're trying to, kind of prospectively design a study that compares what happens when my patients track their scores over time in a clinic compared to other patients. But I'm not being funny. It is actually really difficult to find another provider who is also willing to have their patients track their ProPD score so that we can compare what happens in my clinic versus their clinic.
As you said, the good news is that we don't need their approval. People are welcome to comment without them giving the green light necessarily. Someone anonymously asking about inflammation and basically saying, would it be safe to assume that everyone with Parkinson's syndrome would have low-grade inflammation and treat it appropriately?
No, not at all. Every single patient I've seen for 20 years, I've measured their inflammation levels before our first visit. And I would say 20 to 25% of people have elevated high sensitivity C-reactive protein. I said my goal is less than 0.8. Most people come in, I'd say around a 1.5. I get on their case about diet and exercise, and we correct any deficiencies. If they had a vitamin D deficiency or a B12 deficiency, we fix that. I make everyone start glutathione and fish oil, a couple kind of foundational things. And I would say 75% of people 3 months later go from inflamed to not inflamed. There are some people like infected root canals, sometimes like dental work that has been neglected is probably where we find the most common source of higher inflammation, like levels of 3 and higher usually tells us there's actually an infection going on somewhere, and it's almost always dental. But no, it's a cheap test, and I would say a lot of you who are healthy and eating well might find that you're already not inflamed.
So thank you very much for that, Laurie. Sarah is asking, she's commenting on the fact that you said at some point you had looked at a monthly set of data to compare clinics, and that things could have been different if you had looked at a different month. But she's basically asking a very basic question here. Is there a reason why we haven't done this analysis for more than 1 month? Or is it something you plan to do?
This was me the first week in June getting tired of wondering how my patients were doing. And so I went back and I looked at every single person who walked in May 1st through May 31st. And I put all their charts in a folder, handed it to some medical students and said, how are my patients faring over time? And they came back with numbers I was pretty happy with. But again, I would love to do a much larger prospective study.
I'm sure. So Fiona is asking, she's saying that she takes B12 injections once every 12 weeks. And she's asking you, what should I ask my doctor to be looking for in terms of levels, and how often should I take those injections?
So I have actually, there are some sublingual tablets now that are cheaper and I think more effective than the injections. For Parkinson's school, and I can make a coupon that gives everyone a pass to Parkinson's school, but it's there's a whole class on B12, like a 2-hour class where I talk about what are the labs you need to be able to test to say this is not a B12 deficiency. And so I'll just put one word, I'll make it silver bullet. I'll just make a coupon for Parkinson's school that gets everybody a free couple months for so that they can go watch the class on B12 or the class on some of these other ones. So as soon as we're done today, I'll make a silver bullet coupon.
Oh, that's amazing. So in practice, people should go to, because actually I know that I receive your emails. Which website should they go to?
www.parkinson-school.com.
Okay, perfect. Parkinson-school.com, and you will benefit from a coupon giving you free access for a couple of months to that very interesting, amazing source of information. And it will be no silver bullet. You will activate it after the call.
Yep.
Kathleen is, oh, sorry.
I forgot, no, I'll add it. No, all one word, no silver bullet.
No silver bullet. In any case, when we circulate the recording, we will make sure that we mention it very clearly. Kathleen has an interesting question here. She basically, first of all, she's thanking you for your hopeful approach. You mentioned that we don't have enough dopamine, which is, of course, a very big paradigm as well. And she was asking you whether you have been looking at challenging that paradigm and things such as dopamine reduction theory. Do we have too much dopamine? Some people are advocating that information at the intracellular level, for instance. Is it something that needs to be challenged, or are you happy to let that dog lie?
I mean, I don't think it needs to be challenged. Between DAT scans clearly showing diminished transmission of dopamine, the vast majority of people getting so much better when we supplement dopamine. For me, it's simple enough to say, even if we get into the academic weeds about what's happening on a cellular level, at the end of the day, dopamine improves most people's quality of life quite substantially. And for all the people who are dragging their feet about starting meds, I just want to say we talk like there are no disease modifying strategies. Like, oh, it's been 200 years and we don't have any way to slow the curve. And that's actually not true because in 1975, before we developed levodopa, the average person from diagnosis to death was 8 years. So the fact that you get 10 good years after diagnosis, where your quality of life is still excellent or good before you even start complaining about what a pain in the butt this is, already tells us we have disease-modifying therapies. And I would argue levodopa is at the top of the line. Even if levodopa doesn't necessarily make neurons live longer, I swear it helps you sleep better. It allows you to work out more aggressively. It makes you less apathetic and more likely to reach out to your friends and engage in conversations and less self-conscious and less stressed out about all the things you can't do. There are so many things that levodopa does that makes your life easier. I don't think there is any worldview where we're going to say, given what we see on a molecular level, we think you should go without.
I think it's very important. And I was watching recently the webinar we did with Bas Bloom a year and a half, 2 years ago about exercise. And he was clearly recommending taking dopamine to help you exercise. And I think this is very true. This is a very important aspect. So it is not directly disease modifying, it is indirectly helping you slow down progression through exercise, among other things.
Yeah, I will often tell my patients, take your 1 pill 4 times a day plus an extra half tab on your way to the pickleball courts. People can get a better workout. It's a really amazing medicine. And I want people to not take it for granted. I mean, just this year, I've given lectures and talked to Parkinson's folks in both Jamaica and Kenya. And I'm telling you, they don't even have access to levodopa. And it is a night and day difference. I mean, the fact that we have this amazing tool that we don't want to use, your whole perspective changes when you realize what life would be like if you didn't even have access to this tool, especially as the disease becomes more severe. I think people who have access to levodopa, who are well managed and take their meds on a schedule, are often not appreciating how good they actually have it compared to what the situation a lot of the rest of the world finds themselves in.
Absolutely. We had a month ago, Dr. Roberto Cilia talking to us from Milan about using mucuna in those low-income countries where they don't have access or can't afford levodopa. Unfortunately, we had to take off the video for a couple of months because it contained some information he's using in his unpublished research, but it will be back. I have a great question here from Christopher, probably my favorite question so far. Do you see any differences with people with young onset PD, diagnosed in their 40s, for instance, compared to those who are diagnosed later in life? We haven't touched on that, I think.
Well, I don't know if I have it open here, but basically, this is just data that I got yesterday, and it's fun to be able to show you. Here, oh, look at this is hot off the press by my statistician last night. And I'm showing you because it's so exciting. Oh, she changed it. Anyway, people 40 or under actually we're getting better over time. In the diagnosed below the age of 40, over the following 6 years that we observed them, that was the only cohort that wasn't progressing. They actually had gotten better over the 6 years of observation period. So, or I couldn't pull that up quickly. It was pretty interesting.
So Dave has a question, actually, a double question. Let's just handle maybe the one that I understand best in his message here. Have you looked at Parkinson's personality profile? For instance, people being stoic, analytical, or basically detail-oriented, paranoiac?
I have not made that the focus of my research in particular, but I absolutely talk about it in Parkinson's school, and I talk about it with my patients a lot, and it exists. It's real. Going back to 1968, I believe, was the very first time that a neurologist, it was the head of psychiatry and neurology at University of Michigan in 1968, was the first time somebody's talked about the Parkinson's personality. And he said, this is a badge of honor, right? These are society's best. These are the ones that stay late to make sure the job gets done. They dot the I's and cross the T's. And I see that. I think people with Parkinson's are impressively loyal, like loyal to a job well done, loyal to their spouses, loyal to the job, loyal to the mission. There's a deep, deep loyalty. I think there maybe are a little bit more creatures of habit. And you will never meet a jerk with Parkinson's. Like, they are universally likable people. Like, I have never found a person with Parkinson's that I found unlikable. So I don't know if what that is. I mean, but it's different. It's we have a clinic with lots of other conditions, and everyone at our clinic agrees that Parkinson's patients are a group in and of themselves and universally likable folks. So.
I was going to say jokingly here that maybe that once you discover you have Parkinson's, you reevaluate your priorities in life, which makes you a nicer person, perhaps.
It might be. It might be.
So Thomas has a question here, which is really about how to mobilize doctors who do not necessarily subscribe to your paradigm. And he's basically asking, how can we use a blood panel or other tests to know what supplements are appropriate with our doctors if that approach is not part of their own paradigm? Which is, how do we motivate them to look wider than just cinemet and agonists?
So I think I've given this a lot of thought. Obviously, I don't know where I would have done it by now, but I do think that where all of my work has led me is that I don't think providers are very easy to change, right? Especially once you think you know something, it's really hard to unlearn what you thought you knew. I think training the next generation is really important. And, when I was coming in from an alternative medicine world into the conventional medicine world, I was like, oh, I'm going to do it right and earn their respect. And I'm going to publish in the peer-reviewed journals, and that will make, and once it's published in the peer-reviewed journals, and it's real science, and then they're going to start listening and doing it. That doesn't happen. Like, even though we publish in the peer-reviewed journals, it's another 17 years between when the science says something is true and doctors are actually doing it in clinic. There is a 17-year lag time. And so I've kind of given up on trying to get through to your doctors, frankly. And I have personally decided that I cover way more territory when I talk to patients directly. It is the patients who are going to be responsible for the change. It is going to be you guys annoying your doctors, asking for homocysteine tests every time you go in. It is going to be you coming in with your pro-PD report saying, how come my score has gone up so much in the last 2 years? Can you help? That it is patients demanding something different that is going to be the biggest driver of getting something different, in my personal opinion.
Thank you, Laurie. There's another question I like a lot here about placebo. And the question here is, why is placebo effect so strong with PD symptoms? And how can we tap into that? How can we use this to our advantage, if it is possible?
Great question. So all conditions throughout history, the placebo response has been probably the most reliable intervention we've ever had, right? Like, at every single study, it doesn't matter what we're studying, the sugar pill gets a good 30 to 60% improvement in whatever we study, right? And so it is because participating in a trial, getting attention from study clinicians, knowing you're contributing to something bigger than yourself, being hopeful that something might be improving, helps a lot of different things. But it just so happens that the emotions, hope, enthusiasm, anticipation, are mediated by dopamine. So anytime you get excited or hopeful, your brain makes more dopamine. Right. And so that is especially problematic or lucky for people with Parkinson's, because when you get excited about being in a clinical trial, wow, what if this is the real thing? Even if it's not, you get excited and you make dopamine, and now your tremor goes away. So all diseases have to worry about the placebo response. It's a huge problem for Parkinson's research, because just getting you excited makes dopamine, which treats your symptoms. So the next part of your question is brilliant. Why in the world are we not packaging that? Why aren't we prescribing that? Why have not we developed this entire research track designed at packaging placebo. Like there's something called positive interviewing technique. It is so stupid simple, but like you have an entirely different experience if I come into the room and I say, "Hey, Michelle, how's it going? Have I hope you're sleeping better," versus, "Hey, Michelle, have you started having problems with acting out your dreams yet?" If I treat it like it is just a matter of time before these symptoms appeal, you leave my office thinking about this disease differently. You walk away feeling like a ticking time bomb. So have you started getting constipated yet? Okay, so hey, so have you started drooling yet? Like if you ask questions like that, you are going to generate an entirely different dynamic, an entirely different way, self-talk, where the patient is going to leave thinking about themselves and their disease differently than if you have that exact same patient and say, "Hey, listen, I see your constipation score is a little bit worse, but your sleep and your fatigue levels are a lot better. Let's figure out what we need to do to get your constipation score also good so that we can get you into that green zone." Same exact patient, just a different attitude leaves the patient with an entirely different set of rules once they walk out of your office.
This is so true. It's so true. And I think that a lot of us will have experienced that, sadly, in many cases, on the negative side, because indeed, those kind of discussions are more ticking the box. Are you constipated yet? Do you have urinary problems? Gives you the feeling that it's just a question of time. And if it's not this time, it will be next time. And then it gives you the feeling that the doctor will, I wouldn't say be satisfied, but feel more accomplished by ticking the box that, yes, it all makes sense. There is a question from Patty that is, she's basically saying that her husband is in his first 6 months of diagnosis. He's doing okay, he exercises, but it is hard for him because he works full time. I know a lot of us know about the benefits of exercise. Do you want to say a few words about the benefits of exercise, especially in view of the recent research that tends to confirm that it slows down progression? And Yale University, you probably have seen that as well, had a small sample of 10 people where they even reversed their Parkinson's.
I think the debate over whether or not exercise slows, stops, or reverses Parkinson's has more to do with what criteria we use to measure Parkinson's than anything else. I think any patient or any provider who's been around any notable amount of time will tell you every patient tells you they feel better when they exercise pretty consistently. They sleep better, they have more energy, they digest their meds well, they have less constipation, exercise tends to make everything better. In terms of how do you prioritize it and what do you prioritize? For some reason, our data suggests not only for exercise, but social health racket sports are especially good, whether that's table tennis, pickleball. But there's something about racket sports that I think are especially good. I kind of think of it as one-stop shopping because, you have to be mindful. You can't multitask. There's a social component of it. There's a little bit of a competitive component to it. There's a balance component to it. There's a speed component to it. And so I think that's an easy place to go. And so two things about how to squeeze it in. One, I think we waste a lot of time on TV and social media and things that if we're being honest with ourselves, most of us can find 30 minutes somewhere. I have a rule for myself where I'm not allowed to check my social media account until I've done 30 minutes of yoga each day. I'm not allowed to start my day until I do something, stretch out all the kinks from the night, right? Even if it's just hey, let's just get in the habit of after dinner, let's take a 30-minute brisk walk, right? Like that is better than nothing, and it checks the box for getting some activity. But if you want to know how do you kind of optimize exercise, I don't have much time, I want the most bang for my buck, I tell people it's got to be physically intense, cognitively challenging, outside your comfort zone. And if you want to grow new neuron branches, it has to be so difficult that you're getting frustrated and making mistakes. So you want, if it's coming easily to you, it might be good for your heart, it might be good for blood flow, but it's not good for neuroplasticity. If your goal is reversal, if you want the existing living neurons that you have in your brain to sprout new branches, you have to go make a fool of yourself. You have to go sign up for something where you are in so far over your head that you're turning the wrong way, missing balls, screwing up, making a fool of yourself, because we want your brain to say, if he's going to pull stuff like this, we better sprout some new neurons or he's going to embarrass himself, right? So it is as you leave your comfort zone that your brain starts making growth factor. So you want to be doing something too hard for yourself. You want to leave your comfort zone. Go to a Zumba class, go to a tango class, go to a rock steady boxing, go make a fool of yourself on the pickleball court. Have fun with it. But that actually is medicinal.
That's really good. I also wanted to say that, again, to quote Bas Bloom, again, he's not like our spiritual leader, but he has done a great session on exercise. He mentioned the concept of exercise snacks by saying that actually, if you can't find half an hour in any day of the week, try to take the stairs instead of the lifts, and try to sort of like use your daily life, the other things you do in your life, to try to, for instance, gardening can be a good way of exercising as well, to basically grab a few minutes of exercise left and right. Thomas is making an interesting comment. He says he was diagnosed 6 years ago, age 37, and he has progressed so much. He says that all his consultant does is give him more meds, which give him more side effects. And I think this is exactly the situation we don't want. I would recommend, Thomas, that you have a look at the clinic that we mentioned, the Parkinson's clinic that Laurie is managing, and use the coupon to have free access for a couple of months. You can also look at our YouTube channel, where you will find a lot of other very interesting sessions. So someone is asking about Lewy body dementia and asking whether you would also recommend it as Judy. Would you also recommend your program for people who suffer from Lewy body dementia?
Yeah, absolutely. And again, we're talking about 6 of one, half dozen of another. I mean, behind closed doors, the difference between Lewy body dementia and Parkinson's disease, it is, if you get a tremor before you get dementia, we call it Parkinson's disease with dementia. If you start having hallucinations before a tremor, we call it Lewy body dementia. But whether or not, like the order that you get these symptoms, we have entire conferences where we argue, are these the same thing or two separate things? The patient experience is different. I mean, for a patient who has Lewy body dementia, the cognitive challenges take priority, and we focus on that, and that's what you and your neurologist should be working on. But what we're talking about here today, absolutely, for all of the neurodegenerative Parkinson plus syndromes, I would expect all of this to be the same. And again, we only have, I think it's like 18 people with Lewy body dementia in our study. I can't actually answer the question if more of you don't join the study. So please, for those of you who have PSP, MSA, CBD, LBD, please, even prodromal, if you have kids who would be willing to help. We are now, if you just have a parent with a Parkinson's or consume dairy products, that's enough to get you into the prodromal category. So please, the more people who give us data, even prodromal, especially Parkinson's plus, and especially 10 years out, and especially people outside of the US, we need you to be able to answer some of these questions.
Thank you, Laurie. Barbara is touching a nerve here. She basically says that she lives in assisted living community and struggles to find healthy meals. Now, we have all seen, especially in the last couple of years, how the cost of food has increased all over the world. And there is not a week that goes by without my wife telling me how healthy food is even more expensive. What are your thoughts about people who have limited financial means and their ability to obtain healthy nutrition nevertheless?
So about 8 years ago, the very first time I presented these data at a movement disorder society conference, I can remember having a poster presentation, and one of the docs was standing at my poster, kind of just taking it all in. And I said, "Can I ask any questions? Can I answer anything for you?" And he said, "No, I'm just looking at the list of foods that are associated with faster progression. And I'm thinking this is what we feed people in nursing homes. This is the diet of people in nursing homes, right? The bread, the pasta, the canned stuff, the dairy, the meat, and he's like, I just hadn't really stopped to consider, could we be contributing to the disorder by how we feed people, especially when they're under our care?" And so I think one of the things on my to-do list is, I really would love to make it a side project at some point to, like I was speaking to somebody who ran a memory care facility recently, and he told me that the daily food budget for the people at the facility he runs is $6 a day is their meal budget per person. And what I would love to do, and I think we could do it actually with AI now too, is hey, give me the catalog of the Cisco catalog. Here's the Parkinson's diet. Like, let's do a 7-day meal plan with this budget, with this diet, and start to see, can we come up with some more creative recipes? I think we could actually do that, and I would actually like to be a part of that at some point. And then the other advice I have is there are cost-effective ways. This is what my refrigerator looks like right now. I've been doing this on once a week. On Sundays, I'll go to the grocery store and get everything I need for salads. It's very, very, very cost-effective. And they're called ball jar salads, and you make them upside down so that it stays crisp and fresh all week long. You put the dressing at the bottom and keep the crisp stuff up top. And so at any point during the week when you want a salad, you just dump the whole ball jar out into a bowl, and you have this beautiful salad with 12 different ingredients all ready to make. And it is unbelievable how many more salads I eat in the course of a week when I open my refrigerator and this is what's waiting for me. Once the day gets busy and things start going, no way am I going to pull out all of these ingredients and make myself a salad like this every day. But for me to do it once a week, I mean, for maybe $40, I can make 12, 13 salads that are just ready all week long. So I do think that we can get smarter about how we cook and get more clever about cost-effective ways to make eating easier. And in the online Parkinson School, we have an amazing dietitian, Kelly Morrow, and she teaches a monthly cooking class. It's called Dietary Implementation Ideas, and she shows products that she likes and recipes, and they share all kinds of cooking tips for ways to chop veggies that are easier, cooking on a budget, cook one meal, eat for days. And she has really good classes that kind of provide lots and lots and lots of dietary suggestions.
Thank you very much, Laurie. There's a question from Sarah, who is exactly on the same topic of nutrition and asking an obvious, quite a straightforward question. She says that her father, her dad, has recently been diagnosed with Parkinson's. He's exercising daily. He's been advised by his medical team that he should have a healthy Mediterranean diet. And she's asking whether, in your opinion, should those with Parkinson's disease be speaking to a dietitian? Now, the problem with dietitians, in my experience, is that you find very few dietitians who know about Parkinson's. Even in the UK, where you would expect that there is a lot of variety in that profession. What would you recommend? Because actually we can follow the class that you just highlighted, try to have remote connections with yourself and your team, but finding dietitians in many places of the world that know the topic of PD is very difficult.
Yeah. No, that's exactly part of the problem. And back to the person who asked, how do we get through to the neurologist? The same question is, how do we get through to the dietitians? And we need to do training programs for them. And, about 3 weeks ago, I just spoke at the annual Registered Dietitian Congress on Parkinson's disease. And there were 2 of us speaking. The person who spoke on Monday said, if the patient's underweight, feed them heavy whipping cream and ice cream. And on Tuesday, those of us who spoke said, here are 17 studies that say dairy makes a bad problem worse, right? And so even at the annual conference, there were 3,000 people at this conference, and they're getting mixed messages. One of the speakers at Parkinson said, yeah, whatever makes other people fat, just eat that. And so again, we need clarity. And, I try to be a little understanding and compassionate, because every single neurologist who went through medical school was taught this is irreversible and progressive, and there's nothing that you can do, right? This is all palliative. Every single dietitian who went through school was taught Parkinson, nutrition doesn't have a lot to do with Parkinson's. Like, this is just like, hey, at some point they'll get so bad that they'll have trouble swallowing, and you might need to make their food more swallowable, or they're going to lose so much weight that you might have to feed them ice cream and heavy whipping cream to try and make them fat as they fall apart. But like, most dietitians were not taught that they have any say in how this unfolds. And so part of it is just, again, us alerting the world to an evolving paradigm. No, that's not true. What you were taught isn't true. But I would say let's do a 2-day weekend seminar for dietitians where they can come and actually learn what they can do. And I just posted the pro diet in the chat. And so this is what I use with my patients. You can take this to any of your dietitians and say, here is the diet I am trying to follow. Can you help me with a meal plan that keep like that? That's very doable, and they should be able to do that.
I think that actually we're going to probably slowly wrap up because you have been going at this for quite a while. I'm looking at the other questions. Maybe one thing that would be quite useful is to remind people, because someone is asking about the PRO-PD study and where can I find it? Where can I find more about the study, and how should I participate? If you don't mind just reminding people, I think it would be quite good.
And I'm thrilled to tell you that today we just released 2024 version. So in the past, we have asked you how often do you eat vegetables? And our data says clearly the more vegetables you eat, the better anybody is doing. Now, this new study that just went live today, when you tell us you eat vegetables, there's now a drop-down menu, and we want to know what vegetables do you eat. White potatoes, purple potatoes, kale, collard, bok choy, broccoli, so that we can help you make more informed decisions moving forward. Are all vegetables the same, or are some heavy hitters and some not so good?
Thank you very much, Laurie. And maybe a final question from me. Do you take foreign patients or foreign people with Parkinson's, and how do you then handle the fact that you need a blood test specifically to your requirements for people who are based in other parts of the world?
Yeah, everyone at our clinic sees patients from all over the place. It's really fun to work with people from a global population. I'm personally not taking new patients, but we have other really great clinicians at our clinic. Josh Faranick is amazing. Samantha Evans is amazing. They both have a lot of Parkinson's experience. We all do the same panels. We all kind of practice similarly. We have lots of patients in Europe and other places around the world that do get these Parkinson's panels. Homocysteine can be hard to get in some places. That's pretty important. But yeah, we'll, just like everybody else, we send you a hair kit, we send you the list of labs we want, and you see what you can get done where, and we'll work with whatever we can get.
Perfect. Well, thank you very much. This was a heavily awaited session. And we had, I looked at the numbers, close to 350 people joining, which is probably an all-time high. We hope to have the video that will be Mark's job. So if he doesn't do it quick enough, it will be his fault. But hopefully in a couple of days, so that people can follow. Will you be sharing your slides, Laurie?
Yeah, I might delete a couple of the ones that are hope to publish. So I'll take a couple of the sneaky ones out so that we can publish them. But yes, I can make stuff available.
Excellent. Well, thank you so much for not only for the time you spent with us today, but for dedicating your whole career to helping people with Parkinson's syndrome get better. So thank you very much. And before I let everyone go, I just wanted to say that our next session will be on the 16th of December. And I will have the pleasure of interviewing Dr. Ray Dorsey about preventing Parkinson's. That will be our pre-Christmas event. So Laurie, thank you again so much.
And I'm going to put a plug in for the next session, because I truly think that the next speaker, Dr. Dorsey, I think is probably the single most progressive movement disorder doc around today. In my quest to try and get people talking about it differently, he's already there. And so I do think you are very, very lucky to have him as a speaker next month. And I think that he represents the change that is coming in the profession among conventional docs. I think he is truly a leader in terms of being willing to start to talk about this differently. So show up next month.
Definitely. Well, exactly. He's definitely very much a free spirit. I could tell by my preparation call with him. He might be asking me some questions too. So, Laurie, thank you so much. Have a good afternoon and speak to you soon. Thank you to our audience. See you in December. Bye-bye.
Everybody.